Perfect. Thank
Okay.
you. Thank you. So I'll start out with saying that I'm at UC Davis, and I'm a neuropsychologist by training. And this whole project has kind of come into my world as a blessing through because of COVID. And the first thing we should say, I have these are my disclosures. If you want to look at them more, I'm a peer reviewer, but I don't have any financial potentials of conflict of interest. Um, so the good life is a pretty refined product for public health for Black Americans and Latinos. So, and it's paid for by the state of California. And we've been at this for about 4 years developing. And what we've really tried to do is create a online diet, exercise, and mental health program. So all three of those things that support the patient, not vice versa. In other words, while this is technology dependent, we've worked really hard at trying to reduce the barriers to it, and I'll show you some of those coming up. But in 2020, I had started an in-person clinical trial for behavioral intervention, and the key here was that it was going to support dementia and diabetes prevention in the same way that the diabetes prevention program, which is a Centers for Disease Control diet and exercise program, helps with diabetes. All that we know about diabetes is that it's very similar to the amyloidosis and that's happening in brain for dementia. So we thought we could uh, take the dementia or the diabetes prevention program, put it into place in Oakland, and look at 400 individuals over time. And some people get a lot of exercise, some people get more diet, and we're really trying to adapt the diabetes prevention program to be culturally specific to Blacks and Latinos in California. And then also to just take a look at the cognitive outcomes, because I'm a neuropsychologist, so I like cognition a lot. And so we're getting ready to start. And you can see here this beautiful sports center. So in person, this was all in person. This sports center is in the middle of a very blighted part of Oakland, and it has the really wonderful, it's like a natural occurring retirement community kind of setting where this sports center just outside of the picture is a giant senior center. And so the vast majority of the people who go to this sports center are older adults, Black and brown older adults. And so this was when I first saw this, I thought I had died and gone to heaven because for a long time I thought we'll never get Blacks and Latinos to come into a gym to try to have controlled exercise trials. Gosh, this is going to be difficult until I saw this. And I was like, God has spoken. And we took the diabetes prevention program, we altered it. You could see it was going to work. But that up in the right hand corner, you can see that timing was against us. So what happened in March 17th or 19th? We had, I don't know if you can see the green letters down at the bottom, but the governor of California issued a shelter in place edict, and we had to stop everything. But of course, I had staff hired, and this was a big program. I mean, this was going to be big and expensive. We had staff hired, we had exercise machines, we had A1C blood values, cognitive testing labs built. All these things were built in the sports center, ready to go. So what happened was that my DDPP team turned into a COVID response team. And with money, thanks to Shanette Merrick, especially who's my program project coordinator for this for now and co-conspirator for the last 4 years, really took this where I was like, what are we going to do? We can't do anything. It's like, oh, well, we're going to spend all the money and do things and deliver food, and we're going to get our older adults exercising, and we're going to still address the needs of the community. And I said, yes, ma'am. And then I said, get Governor Newsom, can I spend this money on something different than the DDPP? And the answer, thankfully, was a resounding yes. So the money that I had gotten for that clinical trial all went into developing the good life. And these are just some of the people that deserve an immense amount of recognition for the unbelievable hard work. Because by May, we had turned our in-person aerobic exercise, the blue top box, into Let's Get Moving, an online program dedicated for, in this case, it started out as really culturally tailored for Black older adults. And uh, and this is amazing. So from April to middle to end of May was our first broadcast. It took a Herculean effort, and we actually took over the entire sports center and we built studios, and bought cameras, and people were using their phones, and we got a Zoom subscription, and then we I'll talk a little bit about it. We made it even easier by trying to by the ticketing companies that were in Silicon Valley, just south of us, were all out of work. And so one of them took it upon themselves to create a ticketing system for our not-for-profit. Anyway, we converted the in-person aerobic exercise to Let's Get Moving, the online program, diet. Like the diabetes prevention program is primarily a diet program. And we took all of that curriculum and we put it online. And then we said, oh, this really sucks. And we turned it into a cooking show about food replacement. And all of a sudden, our Black older adults who had never eaten Brussels sprouts in their entire life were cooking vegetables at home. And we partnered with the food bank in Oakland, and my staff actually deliver food still to this day to many of our older adults. And we have a food program at the sports center every Wednesday. And then the social support, the green box. The idea was that we were building a community of health and wellness that was going to be in person, centered around extra activities at the sports center that were going to enrich people's lives. And instead, again, we moved this online. So we call it peer-to-peer support. And effectively, it's like a social hour. And we create these town halls after classes. So people can stay online and talk, ask questions of the health coach experts about what they're doing and how to do it better, for health, for their exercises or their cooking. And then also just meet and greet other isolated older adults, which was so important during COVID and continues. Of course, I'll remind the audience that loneliness is one of the most pervasive mental health challenges facing almost universally older adults. So we have a three-legged program, and it seems to be working. And we quickly recognize that this virtual support, the Zoom focus of this with ticketing that made things easier. I'll talk about that in a second, why that's easier, because I think there's probably skeptics in the audience, but I want to address them in the right moment. They were getting adopted by the older adults because of the crisis. And so the COVID crisis changed, at least primarily, I think it's changed, I'll say primarily in Black America. It forced older adults to get online. And that's primarily through Facebook and with the help of their adult children or the kids that are living in the house with them. But all of a sudden, we had older adults engaging with this new Zoom model. And in these classes, interesting enough, like in the Let's Get Moving class, we find that the adult children are taking a class with their mom, usually mom, because most of our people are women, in order to check up on them. And the daughter, in this one case, lives in Arkansas, and the mom lives in Oakland. And they take the class together. I think it's once or twice a week. And it's a time in which the adult child can check in with mom, and both of them participate in something healthy for one another. So these creative models are working primarily because they had to. I mean, this would have been possible, I think, really prior to the COVID crisis. Okay, all of them put together, let's get moving, let's get cooking, and peer to peer, we sort of badged that as the good life. And uh, we have the URL down in the lower corner, and I can share that with anybody else. And these slides are I'll make sure that they're available for everybody. And again, we have this pretty well developed product with a lot of tech support in it. We have about 2,000 older adults who are gym members, right? So the membership, the gym is still our primary metaphor that we use. Because right now, this is all public health that I've showed you. We do have some research programs about its effectiveness, but this is a public health program. And we've now grown to the point where we have grown a very strong equivalent Spanish language group, which is one reason why I'm speaking here today, called La Buena Vida. Let me just go through a couple of the classes quickly for everybody. These are going to be the classes in English, and not all of them are available in Spanish, but I'll show you those online in just a moment, the Spanish ones. But this gives you the broader sense of the types of things we're doing. We have a Let's Get Moving Brothers, which is a low impact class for older adult men. I was saying that most of our members are women, but we're really trying to reach out and grab the attention of men. That's a slow growing. We have about, I think, 15 men in there about every week. That's not as big as our other classes, which are 75 women. But it's definitely needed, and we're trying to figure out ways to drive men and get their attention to be in these classes. It's actually really difficult. We have Mindful Mondays. We also have a similar mindfulness class on Fridays. So we have a beginning and an end to the week. We have a couple cardio strength classes. So these are, and we rate all our classes by sweat drops, 1, 2, 3. So low impact, like our Pilates or our chair exercise classes have one sweat drop. This one is all 3, is 3+ sometimes because Michael gets taken away. We have a Stress Busters class, which is actually hosted by a dentist in downtown San Francisco who's just been with us from the very beginning. We can't use, right? Zumba is a copyrighted thing, but this is basically a Zumba class. And then we have a mental health class for men, and this isn't just older men. This is open to all men. And this has been very popular. We discontinued it this season as we search for a new group leader, but we had about 60 men in this over time, over the last about 2 years it was running. Some Pilates, stretching. We're looking to get into yoga more and more, but we don't have a yoga class yet because we haven't found a good instructor. Then we have these cooking classes. And so these are, I mean, everybody loves it. This is probably most everybody takes these cooking classes. So we were fortunate enough in a second round of funding to be part of the state of California's Healthy Brain Initiative. This is a sponsored project by the Centers for Disease Control. And this is a really natural fit. So for those of you who may not be so know about the Healthy Brain Initiative, it's public health directed at older adults for healthy brain aging. And this cartoon is some of the 4 pillars about it. And I think we're made for this project because we're accomplishing all of those things. And in a separate talk, I talk about that more. But we're doing this public health service that's really in line with Centers for Disease Control's best practices. So back to Camino Buena Vida, because I think this is the URL is down in the bottom left again. Camino Buena Vida. You could imagine that La Buena Vida is a popular moniker for other programs, from like nutrition shakes to gym equipment. but we have a URL, both the Good Life Path, or the idea here is that there's that you're on the road to health, that it's an action, and that you're going to change over time and take the path to health and wellness. So let me see if I am able to just drag and drop. No, I'm not going to be able to. Wait just a second. I'm going to switch. Do you see I'm not sure. Do you see the website interlude slide? Yes?
Yes.
Okay, good. Now you probably see La Buena Vida, the splash page. Okay, good. Good. So here we are, Camino Buena Vida up at the top. And if you want to join our classes right there, we'll go there in just a moment. And here's a how to do it video. And if I play the videos, I'm afraid of the lag from California to Texas. So I asked Neira to download the YouTube. This here is our welcome version for the Latino community. Would you play that, Neira, for everybody? That wasn't all of it. Could you? This just goes through and tells you a little bit about the program. That's one of our live sites. So we found within the Latino community especially, we had to have these watch parties. So I'll talk about them in just a second. Thank you very much, Nina. Oh, no. There we go. We're back to the website. And let's go ahead and I won't belabor this, but if you want to go in and play around, here's why do we get to let's get cooking here? Am I in the wrong? Bienvenido. Well, let's go to look at the. I know this one works. So here's our classes, and the four exercise classes that we broadcast every week, all said and done now. This season, for example, we break it up into 4 seasons. Spring, summer, fall, and winter. We have 13 classes going on this season, and these are our 4 of them that are exercise and all in Spanish. So we have a dance class, we have a chair class, especially because we've now started to, we are in the senior centers, this one in Downey, California. And this is a class that is, we make specifically for seated folks so that they can, this is primarily a wheelchair class, but you can follow along at home and just if you're in low fitness level and participate. And we have a person who's trained specifically to be able to do this well. And then you subscribe. And this is a little bit difficult for some of our seniors. And so we created a customer support team. Let's see if we have a picture of them. And call in or you can Zoom in, but usually people will call and ask for help to get online, and we'll register, do all the hard part of getting them registered online for them. We have a health fair coming up in Oakland, and you can learn more about the village, but in particular, it pops you over to the English version, so um, you can get a ticket to the village, and it'll give you a map. And oh, here's the map. That's where we're going to have it. And then our sponsors and stuff like that. So let's go back to my talk. How are we doing on time? Great. And I think I go here. And there we go. So I think one of the successful things, you guys can see this big white screen with text all over. Okay, great. I think one of the key things for me as a clinician is I want to deliver a product, an intervention, a behavioral intervention that's clinically meaningful. And so I think it's a big part of this is the mindfulness and the social support that comes with the classes, so that people, when they enter this community, I sometimes call it sort of more of a nerd term of like a digital commons, like you're in college or something, but it's really a community of support. And it's a community and a mindset of wellness. Everybody there is focused on getting healthier. There's not distractions like ads. It really is. We screen out people who would otherwise be taking advantage of. These are qualified, vetted members of the community focused on health and wellness. And there's really no other monkey business. Like, we're not trying to sell anything. And I think that's just so key. The only thing that we ask people to do is listen. They don't have to enroll, but listen about clinical research. Because the idea is that when they're in this support, this community support, and there's a mindset of wellness, and that they're more open and responsive, and we're building trust over time. That's the hypothesis. We'll see if that really shakes out. But we're trying to deliver clinically meaningful content, create support around it, and then also ask our seniors to consider clinical research that's been vetted, that has an IRB, and that has gone through our vetting process with our community action board, as I like to call them. So it's not just me saying, I say whether or not it's scientifically sound, but my community board says this seems appropriate for our community. Moreover, as a clinician, I want to think about primary, secondary, and tertiary prevention. So there's a structure to the classes that we're trying to give, and they're all driven toward different stages of aging, healthy to pathological aging, and really trying to meet the older adult at different points along their trajectory through old age. Okay, so just a splash page that I usually show up. We've got at our height, we're not quite there anymore. We had 40 people employed, 2,200, over 2,200, because we're now added more people. I think it's about 2,500 this year. We're in 41 states, even though California pays for it all. 6 different countries are listening, and we've given away ingredients to over 1,500, almost 2,000 times now. The idea about La Buena Vida now is that we're syndicating to other counties, other community-based organizations, other ADRCs, wink, wink, Dr. Maestre, we've created like an MOP, or a set of standards of operating, and there are different levels that we can imagine that an organization can engage us. So This is a not-for-profit that's been established that supports the public health program. Researchers can come from the outside and get sort of free advertising or free, appeals. So we'll send out emails, there'll be splash pages, anybody interested for a research study, and that's up to them. But we hope to, and this is working, where we're engaging like senior centers, and we have these watch parties now where there's a staff at the senior center that basically turns on the TV and gets everybody together for Baila Conmigo on Tuesdays. And those folks get checked in as if they've attended class, because the staff person gets trained. That's the only thing. They have an app that we've developed for their phone. And they're recruiting people basically, and we've grown actually quite a bit. La Buena Vida started out it was very weak for the first many months, maybe a year. We now have over 400 people enrolled in La Buena Vida, and that's because these watch parties have been successful. And so that's, they're promoting existing TGL content. You could host a class, and we have all these MOPs about how to set up the cameras and how to get online and how to use our, interface with us to get tickets sent out. Or you can also host your own events. So that's sort of like one leveling up, if you will. And we have instructions that are being curated over time to help individuals do this. And that's part of the Healthy Brain Initiative money that we got to help. We're in 5 different California counties helping those Department of Public Health get people online for the good life. Here's an example. It's its own independent site. It's not part of La Buena Vida. It's only in English right now. And you can see there's all these menus about expansion and making the participant journey good. And we've had some really great graduate students help us develop some of this stuff. And it would be wonderful to have some postdoctoral fellows and RICMAR scholars to help with this kind of thing too. Okay, we've got this customer relations management system. And the only reason why I show you this slide is to say that we get very detailed information. So we know what older adult, in this case, Cheryl, what's her level of participation over time. And sorry, my phone's going off. And then what classes she's gone to. And these account credits and stuff like that are sort of gimmicks that we're thinking about using, like getting a reward system going so that you're rewarded for attending more classes. You get to a certain award level, you get a t-shirt or a water bottle, stuff like that. But the key here is we collect data. And we collect data by zip code. And so here's the zip codes for San Francisco. And so we know all of our participants where they live. They don't have to give us their whole address. We just ask for their zip code so we can track them. There's just very little information that we require. Age, gender, education, and zip code are the 4 big ones that we have on everybody. And that way I can report to the state that we're not just stealing the money. Okay. Overall, I think the good life has become greater than the sum of its parts. Just because it's clinically meaningful and instrumental, we're trying to be smart about how we're doing this. We're using the exercise is medicine model from the American College of Sports Medicine. The food is medicine, that is the copycat basically from nutrition and dietetics. Peer-to-peer support. So JAMA, this is a great article about how peer support really helps mental health outcomes in older adults. We have a capstone health education talk. We could do a lot more with that, and we're just limited by funds and people and hours in the day. And then things like Brothers Building Brothers. There's really nothing else out there like that to have what we call barbershop talk in this case. Brothers Building Brothers is the men's program for Black America, for in the good life. And underneath there's a couple programs, and one is called the Barbershop, which is We have a group leader that's doing peer support for Black men throughout largely Oakland and San Francisco. And there's really nothing like that online that I've seen in the same way. And we're trying to do all of this in Spanish now. We're not fully built out, but we're definitely doing exercise and food, and we now have a mindfulness class in the peer-to-peer category. Okay, this has got too many words for most people. The title up at the top is the most important thing. We're working on research projects to validate the program as a whole. So we have qualitative interviews with all of our members. We have something called the effectiveness study where we're mailing out free Fitbit accelerometers and body weight scales, and people get paid and they take mental health surveys on their phone. And then we collect the data from their Fitbit accounts are linked to us. And so we get sent their walking and their body weight data. And we have our customer support calls in, reminds people to take classes, reminds them to how to use the watch and how to do the body weight. The scale is automatic as well, and it all works through their phone. So the limitation to that program, of course, is someone has to have a smartphone and know enough how to use it. But it's not too bad. That's kind of like who we're appealing to in general. We also, again, we still have the dementia and diabetes prevention program. So we started that clinical trial back up. We actually just finished it. And more importantly, in that trial, what we ended up doing as the primary outcome is developing a 1-hour health screen that, let's say a YMCA wants to run the Good Life, and they're using some of our content, but they're also doing some of their own. Once a season, the idea is that once a season, they'll do a health screen, a free health screening check. They can use our format, and if they use our form, they'll be able to the older adult can take a picture of the form. They could text it to us if they want to, completely anonymous, and then return. What we'll return is a report, red light, yellow light, green light by different categories: heart, brain, blood, categories. And you'll get and if it's a red light, it'll say go right to your doctor. And then the older adult not only has their recent health screen, a picture of their health screen, but they also have the report, and they control it, and they could take it to the doctor. And the idea is that the red light, the stoplight, is about getting people to the doctor, so you're catching diabetes and heart disease earlier. We just did our first healthcare analysis. Oh, I have data for that. Let's see. Oh, I have nerd stuff now for you guys. We presented this at the Alzheimer's Association International Conference recently. This just has a pretty picture of California and all the counties that we're in, and we can do these heat maps with the zip code data, and it's just a demonstration that the data doesn't suck. We're in 39 of the 58 counties, and working in 5 particular counties that are funded with CDC funds. We have 14 classes per week, Spanish and English, all this empirical data, hundreds of attendees a week with thousands of watched hours. And so you can see over time, the only thing you need to appreciate here in this poster is that we're growing very fast. Okay. Here's some of our demographics. And the thing to appreciate here is high school and lower, we're not just getting well-educated Blacks and Latinos, we're getting common, average, well-sampled people in need kind of Blacks and Latinos. Okay. And up at the very top, you see that we have the number of active participants this season. So we have 464 English speakers in the Good Life exercising with our programs this season. And overall, it's about 1,700 people, members, who have ever used our services. People tend to go on vacation, they come back, and they and we're analyzing these data now, but it looks like we have people, if you've taken our classes, you stay in them. And then if you and we're trying to learn more about the people who have started and stopped. And so we're taking a qualitative interview approach with them to say, what was the barrier? What do we need to offer? Different classes, easier classes, language barriers. You just didn't like the health coach, whatever. This is our recent a draft, so these numbers will probably change. We've been using a 2008 study that was with an economist that we're working with to try to monetize the amount of money that Center for Medicaid for Medicare, CMS, what is it, Medical Services is saving. And so if you have the first year, if somebody gets hooked and they start exercising, the savings per participant is $2,818. That's the amount of money that the healthcare system saved because that older adult joined the Good Life and used our services at least once a week. So that's not even, some of our people are in classes 4 times a week. It's pretty. We have 237 participants like that. And so our total savings was for healthcare about $667,000 for just those people over time. The longer that you're in it, the more money that gets saved per person. And I'll point out that in year 4, we have 82 people from the very, very beginning. And over those 4 years, we probably saved about $10,000 per person. And so, the cost savings are really significant. We're trying to make sure these numbers are right. These are kind of the first pass with the economist and a graduate student. So, the fun continues. And like I said, the data doesn't suck. We're learning something important about implementation of exercise, diet, and mental health support classes in Black and Brown communities, at least in California, if not further. Okay. I've sobered up over the summer. We were not competitive in the last research cycle for the California Department of Public Health, which was very surprising, disheartening, I'll say. We're on track to run out of money in the new year. So I'm inviting any and all collaborations, and I'll end it there so we can just talk about the program rather than me lecture about it, which I think is a lot more fun. And then I have some slides for questions and things. So like this really cool one or that one or this one. We're able to have a conversation now, I think. Was that about right? Did I hit the timing mark? I could talk more, but I like talking about, let's get me stop sharing. I don't know how to stop share here. Oh, it's over here. There we go. Well, thank you, Rosa.
Beautiful.
That's very nice.
Really beautiful, Dr. Johnson. I think we have a lot of things to learn from this experience, and it's definitely a very good model to follow and to emulate. I would like to invite the audience. If you have any questions right now?
Dr. Maestre. Oh, Sylvia, you're next, but Dr. Maestre first.
Thank you. Very excited to have you, Dr. Johnson, with us and share what you think and how you are envisioning that we can bring the Buena Vida to the valley, because that's what I want. I want to bring Buena Vida to our older adults, to our city, and I want to contribute as much as we can as a team as well, because this is a quite talented team.
Yes. I'm excited about your team a lot, Dr. Maestre. So I'll say a couple things that some lessons hard learned um, over the last year and a half about La Buena Vida. One is that I have trouble. It's an intersection about my health coaches. They're usually younger, and the younger generations in California of Mexican Americans who we're focused on right now don't speak the best Spanish. And so we've had to develop classes in Mexico. And so our partners at La Universidad de Autónoma de Baja California, we pay them some money to actually produce many of our exercise and nutrition classes now. And so I think we have a really good, culturally competent product. And I'd like to know how the Texas experience, especially in the Rio Grande, is similar or different. And we're going to learn that by starting some classes. And it's going to be difficult and very rewarding, both at the same time. And I'd love to have, I think, classes that are better serve your participants, because I imagine that Texas is fundamentally different than California. For our LA and our San Francisco area, Bay Area, North and Southern California, and our Mexicans in Ensenada. So your group may be younger, maybe older. I think that there's probably more multi-generational and culturally more Mexican than Californian culture. All these things need to be expressed in classes that you create for your participants with your competencies of who they are and what they need.
I totally agree, and we are very excited of our most recent agreement. I'm not sure where we are in our agreement, but
Omar's been saying any day now to me for like, I don't know.
okay, but I want everybody to know that we are very proud of this partnership, and I think this is going to be very transformative for our group and for the actions of our group, our team, but most importantly for the community. And one thing I have to tell you, it's one thing that hit me when I came here is that I see so much talent in the people. It's like everybody knows how to sing, how to play, how to dance, the exercise, people that so it's something that I think it will show. It's kind of the language is a mix, and we became more comfortable with the mix. We wanted to kind of put the people either in Spanish or English. I mean, in our daily life. But the reality is that it's always a mix of things, and we ended up speaking like that. Is a different is a so I'm very eager, and I'm not bothered by the either way, only Spanish or the Valley type of talk, which is really a mix. So very excited. Thank you very much, David. And I'm sure that not only we are going to do a public service with your idea, initiative, and support of your group, but also that we will advance the science of implementation.
Yeah, and I'll add, we have done sort of an informal count, and I'm trying to figure out how to I don't know, verify, I suppose, because since we're a public health program, I don't know who's been in what research program, but all told now, it seems to me about somewhere between 350 and 400 of our good lifers have been in research programs, have been in a research study or two for the last 2 years since we've been doing this. So I think there's other opportunities to be looked at. What's exciting is that we're getting to isolated older adults and giving them some support. And by doing so, we give them a path forward to even come out and get health screened, to learn non-state, that ageism, all the ageist stereotypes that we hold about forgetting is just normal. That's out the window. And we have opportunities to do immense amounts of health education. Sylvia, you had your hand up, but now it's down.
No, you just answered my question. I was going to ask you about how many people are participating in research programs, and if this has been working for getting research subjects.
I will tentatively say yes.
Okay.
There are notable voices that say, no way, no way, Jose. No, I'm not going to do that. But I believe that over time, we're going to make a difference. And so one of the studies, one of the NIH grants that I've been proposing is to try to track the stages of volunteerism, because I think people in this space of community start, if they know about the epidemiology of these diseases in Black and Brown communities, that in their sense of community mindedness, it naturally says, I need to do something about it. I need to participate. I need to help. So that's one reason why I call it the path. It's like a garden path to becoming engaged in clinically meaningful, and really the first stop is almost always behavioral. But I think we'll be able to convince a few people to get an MRI, but largely it's about behavioral interventions at the first blush, and then
and let me add that it's amazing what you told us, but we are finding several specific needs in the population, in the community who's participating in our study. And one of those needs is the need for care on depression and mental health. So they don't know about it. They have to be educated on how to work with their depression and where to go and what to do. But I think we are having a lot of people, and they are not as old as we think. We are getting people from 50 to 60, a lot of them with high levels of depression. And every time I see one of those participants, what do we have to offer them? What do we do other than looking for, refer them to a doctor or something like that?
So I have a bilingual clinical psychology graduate student that's just starting with me in December, and one of her main tasks is to take in both Spanish and English. We're going to do reminiscence therapy, and then particularly talk about like a social club, but it's really about building pleasant events, a schedule of pleasant events. Loneliness is, the number one mental health crisis, and that's generating the anxiety and depression that we see in at least our healthy older adults, right? Dementia is a different story, but yeah, there's lots of work to be done, and it's different in the Latino community than it is in the English speaking community. And I think it's probably different between California and Texas, because I think it's the cultural center point shifted, and it's different, and a different perspective on what it means to say, I feel blue. It has a different cultural meaning. Omar?
Okay. Thank you, David.
Omar, you've been waiting patiently.
Yeah, no, that's fine. All the information is pretty good. Thank you for your talk. It's really amazing what you have done. My question to you, and this is a variable that I have seen in many programs and this is a style, the CRM, the software. Like every program that has a robust CRM has a really great success rate. How do you incorporate your CRM into what you're doing?
Well, so I was very fortunate to sort of come by this CRM through the ticketing company, because that's one of the baked in pieces of the ticketing. And so it's well integrated. And we were really fortunate that they were completely unemployed and bored over COVID. So we got to basically benefit from their tragedy or their suffering. And how we use the data. So we get we know what older adult goes into what class on what day. There's a little bit more work that could be done because we don't actually know how long they stay in class. Sometimes I tell the NIH I do, but don't tell them. And we're figuring that out. So dosage, we know dosage pretty well. If you say exercise is medicine, how much medicine are you taking? Is it 1 drop or 3 drops, right? We did the drop thing to tell people what they were signing on for, but we also did the drop thing so that we could weight the amount of exercise and the dosage. So lots of dose to less dose on 1 to 3 sweat drops. How we're using it. So the first thing was just I had to report to the state that we had people exercising, coming to class, and verify that. But over time now, for the effectiveness study in particular, right, we're correlating their attendance over time with their step counts and their change in body weight and their change in mental health status. So we're collecting longitudinal data about their attendance, and we can, in the same way that you would in any observational study, correlate what was the antecedent to the weight change, what was the antecedent to the change in anxiety, and is it aerobic exercise classes? Is it just social nutrition? Was it weight loss? All of those questions can be probed in these data sets. And we worked really hard, and many thanks to, again, the staff that I have working with me on creating, the software interfaces that go between Google, who owns Fitbit, and VBO and RedCap, and bringing it all together and not totally screwing it up. It actually seems to be working. Customer support. We also use the data to do you haven't come to class, Mrs. Lopez. What's going on? Why aren't you in class? You were so good. What happened? So it's a way of checking up on people. And we're now talking to Cal Ames and the Medi-Cal people about creating flags for when somebody's attending and then's not attending, right? The change in attendance rates. So that we can call them and get them screened if something's going wrong earlier.
So
and then there's all sorts of crazy ideas that are out there, but those are the main ones that are realistic that we're actually doing.
Just to finalize my topic. So do you provide tracers, like individuals tracers, every time that they go to the classes, or to collect data?
Tracers. Tell me what you mean by
like the Fitbit, the Fitbit.
The person gets signed into, what happens is they get consented into a UC Davis research program, and there's a data exchange agreement that's set up. And so the person gets a UC Davis purchased and monitored Fitbit, and then Davis gets the data from the Good Life. Not everybody in the Good Life gets a Fitbit, but everybody in the Good Life gets offered to be in a study where they could get a Fitbit.
So that's what we need. Thank you very much for the answers.
Jesus, how are you?
Hello. Yes. Hello, David. Good. What about you?
I'm fantastic today.
Yeah. Hey, David. That was a great presentation, and I get to comment or question and the second question was based on one of your replies. So, did you do, or are you aware of studies in which or reports in which they compare the willingness and the participation rates over the study period between groups of people who initially receive sort of information, as you mentioned, the epidemiological data versus some other group that, I mean, probably just saw one pamphlet and that was it. Just to see to what extent having the kind of initial impact about you mentioned the epidemiology of the disease, how much would that affect their willingness and participation overall the study?
Right, that study could be done, but I haven't figured out a good way to measure or quantify health education. And so, for example, one way could be in the RICMAR, where you have such a highly interactive participant pool that's coming in, and you could give classes and then give follow-up sort of stages of change, but only for volunteerism or knowledge gaps. I think ageism is a big thing for older adults. They just don't have, there's no handbook for aging, and especially not Black and brown aging. And so people assume that forgetting and dementia is an inevitable part of aging, that I'm going to have to suffer, that my and moreover, this concept of anxiety and depression within Latinos is really weird, slippery stuff. I mean, I think everybody's probably seen it. Like, you ask Mrs. Lopez, do you feel blue? And she says, well, my daughter just got a divorce, but my son has a new job and we have a new grandson. So I think I'm doing okay, right? And it's the external locus of control is fascinating. So there's unending work to do in this, and we just haven't started it. So Jesus, let's write a grant.
Okay, and yeah, and that sounds great because I mean, so at least from, I don't want to say like from the Latinos culture, at least like of course we're going to have people who would not be willing or who would see it not as positive as we would like them to see a research project, but at least I find it hard to believe that if we are able to communicate, to disseminate what is going on with this of Alzheimer's disease related disorders, with hypertension or cardiovascular diseases and diabetes from a research perspective, that we have our unique experience, our unique findings, that we can communicate this to the people. I find it hard that they will say, I'll not contribute, or just gonna run away, like I'm not interested. Of course, we're going to have people who would not, but I listen in the Latinx community. If we do it in the right way, in the authentic way.
There's a lot of creative ways to get to those people and to talk about it in different terms. And one thing that I've thought about is the idea of a local champion. So just like the promotores, but they're really also just another little old lady talking to another little old lady, and the trusted source of information. Is that the hairdresser? Then let's talk to the hairdresser and get her fully on board with this and get her a poster so that it's a conversation starter in the beauty salon. Right? It takes you young people to think about these things. I'm too much of a curmudgeon to actually be able to come up with a successful study design. So figure it out, man. That's what I say.
Okay, I figured it out, and thank you. And the last one is a comment, because you actually we've been working in a systematic review.
You have to speak up a little bit. I'm having trouble hearing you, Jesus.
Yeah, that we have been working in a systematic review that has to do with. I'm just gonna summarize. It has to do some part about architecture, which Dr. Glady has been interested really interested for a couple of years. And when we were writing this section about architecture or how imageability affects neuroscience, specifically in cognition, you mentioned the part of not only doing exercising, but that gave them a chance to interact, to socialize. So when we were summarizing those findings in the architecture and neuroscience, I remember 3 studies that came out about showing the benefits of sharing a space that's besides exercises, but will also bring kind of a special locations of culture to people to share there, and that
Coffee
showed
shop.
benefits in cognition.
Right.
Yeah, it could
Coffee
be.
shop.
Yeah, but you need those spaces. Like we need to kind of adequate to make the environment for a proper environment for the specific people, because some studies was in Japan and the other one was in Europe. So you want to adequate there. If you're a Latina, I'll expect some space that will feel attract to it. But those three studies showed a benefit of the socializing, the part of socializing with cognition, with less depressive symptoms as well. So, and you commented that about with exercises, beyond exercises.
Well, sometime we'll talk more because we're in danger of spinning off into nerdland. So let me take Dr. Ramirez's question,
yeah.
but there's lots of things to talk about with that.
Yeah, sure. Thank you very much. Yeah.
Dr. Ramirez?
Hello, David. I'm sorry I joined a bit late on the talk. Was when you were explaining your website of the Buena Vida and stuff. But so I think I got the the main aim of your project and your good results. I wanted to ask you if you have any have you employed any metrics on terms of biomarkers to look at your positive impact on the the brain and cognition and stuff like that? I'm telling you because I do proteomics, and I'm interested on BDNF. BDNF is because it also has a role
So
on
the group in Ensenada is very interested in BDNF, and we had a paper but on exercise, but not in the Good Life exercise. They have a very controlled exercise lab, and with a metabolic cart and everything, and they are doing great BDNF work. And we did great BDNF work back at Kansas under controlled trials. So in this case, the main biomarker that I have been really interested in is associated with an exercise stress test, and cortisol, salivary cortisol changes dramatically in fairly normal older and younger adults. But if you're chronically stressed or traumatized, the cortisol response pre-post is blunted because you've downregulated all your cortisol receptors. And this was first seen in active duty service members who had been traumatized in Gulf War conflicts. And so I've been interested in taking that paradigm because it's a exercise test that can be done fairly easily. And cortisol is a slippery thing, and so this makes it a lot easier to work with. And so that's been a biomarker that I've been interested in for aging while Black is one way I describe it, or aging while Mexican in America is a stressful event. And looking at aging in Mexico and aging in Costa Rica and aging in Venezuela and aging in Texas, right? There are plenty of great biomarkers. I think that you have to stick with blood draws. We're not going to magically produce PET images from these people. So those are some of the thoughts that I have. BDNF, certainly, it's blood draws for that, I understand, are pretty controlled. And so, and you want to know your dosage probably a little more refined than we do, but we give you good dosage. So you could do BDNF pre and post some season and know the dosage in which the older adult got to go to exercise. But that may be kind of coarse in the index that you need, because BDNF is a small range of index, and I don't know what causes it to change terribly well. So maybe you have better ideas than I.
Oh, well, it's interesting because I just I'm writing a paper where I put these diabetic diabetic mice to exercise and the wheel and the cage, and they improve their the glucose. I look at the gluconylation, which is a PTM,
Yeah.
I just ordered antibody because I want to look at BDNF because I found that paper. I don't know if it's your colleague's paper where they did exercise to elderly patients and they increased IGF and BDNF on the blood, like
Yeah, that's probably the Illinois group. The Art Kramer's group does great work on that from
okay. So
University of
that brought me
Illinois.
back to the idea because I tested IGF on this on in vitro as a good factor, but we know is IGF is expressed or is secreted with
So are
exercise.
you suggesting, Dr. Ramirez, that I have a La Buena Vida for mice?
No, I suggested you have a very rich source of
Yes,
research,
for
like
human
with
data.
yes, exactly. That's what I'm.
Yeah.
I also
I'm
need
joking.
a grant, so I'm just telling you that if you want to do stuff, we can probably do stuff together if you want. We
That
have
would be
the
great. I need to introduce you to some of my colleagues in Ensenada who are
well,
really
I'm Mexican and I know a lot of people in research, right, from Mexico
from
too.
uh, I don't know why La Buena Vida just stays only on one side of the frontier.
Okay,
Marcy?
but it's an
Hi,
excellent talk. I really congratulate you with the work you're doing.
Thank you.
hi, Dave. Sorry, I joined a little bit late, but I didn't miss the part I'm really interested in because I'm the economist in this group, and your healthcare estimation is covered in the very last session. Because I'm very curious about the methodology and approaches they used in the analysis. Can you just provide a direction for me? Because later I'm gonna use it for projections on our project and grants.
So I have let one of my young post-baccalaureates who wants to go to graduate school work with an economist that's in my department. I'm in the Center for Health, what is it? Chipper, Policy and Research. And he's basically said that it's kind of the wild, wild west on these projections. So you want to have good transformations for $2008 to $2024, and then how do you match one exercise dose to in one
Exactly.
paper with an exact
Yeah.
exercise dose in another? And so we chose the one that we thought was the highest quality and closest to what we were doing. And then we were thankful that our data we could we knew how much medicine was administered over time and per season and per year, and so
Okay.
we could take our data and sort of try to match it to theirs so that it
Okay.
was more or less apples to apples.
Okay.
And then we just multiplied it out. And
Okay.
I have a meeting on Thursday with that group to go see all the things that are wrong with those figures, but we're
Okay.
working on them, and I'd be happy to share them. And I know Ethan Frangella would be happy to share them with you.
That would be awesome. Thank you so much. I think it's if it's economist, it must be something related to propensity score matching or something, because they're going to
Yes,
use principal.
exactly.
Yeah, it's something like that, and they are basically, leverage the characteristics of patients or the participants, and compare them, like you said, apple to apple, something like that. Yeah.
Yeah, and propensity score matching is a dark art. But it's more or less at the end you convince people that you have similar units of comparison. But yes, it is a something in which I'm trying to learn and take good care because the projections do go all over the place at the beginning until you figure out what's going on.
Yeah, because it's very impressive. You report that the healthcare could save like 10,000 per person. I was like, that's a lot of money.
Well, that's a 4-year exerciser. So if that's a believable number if you think 4 years, older adult went from sedentary to active
Yeah.
for 4 years. Um, that's a believable number, I think.
Yeah. And I think that's, because we're from a low income region, and even like 10,000, it really like it's a good money for everyone.
Well, so the sin in there, I'll be honest with you guys. Hopefully you don't review the paper. Is that the Ackerman paper looked at people who had an HMO, and so everybody was in a health whatever maintenance organization, and most of our people are uninsured with Medi-Cal, and so I think the savings are bigger because they're not going to the emergency room, right? We have to make certain assumptions, like they would if they were to, if they were to go see the doctor, this is how much they saved, right? But they don't go see the doctor until things go to hell. And then it's then it's an emergency room visit. And that's an orange, not an apple, right? And so this is the thing that I'm conceptually wrestling with, because we don't have exactly comparable units.
So you mean
Although
there's
they are racially balanced, they are different SES.
I see. But so there's I think that's the quality measurement issue. It's not only like quantity, like how many hours you do the exercise. It's something related, like, we're human beings. We're very complex. It's not only numbers. But I'm gonna follow up with you about the Thursday meetings. What kind of approaches for details.
Email me on Friday or Monday or something, and then Ethan will probably get back to you.
That's awesome. Thank you so much, Dave, for the great presentation. We're gonna talk more later. Thank you.
Super. Are we good in time? Good time, Hector? Do we have enough time for Hector's? We do. Okay. Thank you, Nader.
Hi, Dr. David. So just wanted to let you know that was a great presentation. I came a little bit late, but I'm currently working with the clinical core here and with Dr. Maestre. I'm the clinical research coordinator. And I was discussing with her a while back about implementing some sort of, program for our participants, because most of them, unfortunately, have high blood pressure and the diabetes. It's very, common here in the Valley, unfortunately. And since this is kind of my area of expertise instead, because I'm an exercise science major, I was a diabetes educator and an exercise physiologist. So I was doing exercise prescription for people with high blood pressure and diabetes in San Antonio. And then I moved back here to Brownsville, but just wanted to, let you know that that's really interesting. That the exercise is medicine. That's something that I used to say back to my patients, because they were, losing weight and improving the A1C and everything else, blood pressure back there. So it will be, I think, something beneficial for people here in the Valley as well. So if you were to bring this program over here, that'll be, very interesting. And I would like to contribute to the program if possible, right? Later down the road. So I just wanted to add, that.
There's things you could do immediately. We're working on this, actually having a prescription pad.
Oh.
And so I've taken like a couple stabs at it, and some students have, and I got different ideas. And there's a couple barriers where the docs are like, this is a great idea, but I'm not going to give you my patient's information. You're going to have to get it yourself. And so there's some amount of barriers to the connection, to the continuity of care. So, and how you do that in the Black and Latino communities is really different and interesting. And how do you make it so that the front desk doesn't have to get them enrolled? And then also, like, the idea of the Snappy that you take at your health screening, and you can take it to your doctor. These are great public health assets that sound simple, but are remarkably complex to make them work well.
Oh, yeah.
So we'd love to have you have the right skills to help that.
Oh, okay. Just let me know down the road.
And we are counting with Hector to support this program. And one thing that I I think about it, and we have also Kendra Stein with us, and she is the chair of the primary prevention committee in the BOLD initiative here in Cameron County.
Oh, you have a bold. Okay.
Yes,
Yeah.
we have a BOLD, and tomorrow we have our next meeting. Omar also is part of that, and I'm part of the primary, secondary, and tertiary group, the prevention groups. But so I see this in two different ways, of course. One now, and how it's justified from our point of view, is to support retention in the ADRC and BCID. And the other is to actually look at the role of family in supporting participation in this type of activities, group activities, online activities for the older adult. I think that's our justification from our research perspective. But from the public health perspective, I'm very enthusiastic also in bringing that at least to this county, Cameron County, that it's fully committed, that has the funding for implementation, and is actually designing now a series of qualitative initiatives to gather the information and the preferences from the people. So I'm very eager to support the public health initiative as well as the research initiative. So in one arm, you're going to have, or we are going to have, people that are already enrolled, and they are very committed. They are, already have the blood taken, the AD biomarkers and the MRI
Would
and
be
all that.
fantastic. Yeah.
And mostly of Mexican American origin. And then on the other hand, in other arm, this is going to be people that we want to reach out in the community. I've been advocating for a catchment area study so we can really understand the population better. I am a big believer that we have to knock on the doors and find people where they are. On top of that, so as I mentioned, the culture in the Valley is very rich by fortune, I think, in terms of music and other art, other type of art, and even like yoga and that kind of also mindfulness type of activities. So I think that to be truly sensitive, culturally sensitive, we will have to incorporate some classes also that bring the music and the arts to be more accessible.
I would love that, Gladys. I'm just too much of a Philistine to know how to do it. So
And we have one of our RECMAR scholars also. She leads the expressive art program
cool.
here at UTRGV, and she's always talking about the importance of music. And we have Nay also, which is a professional musician, and his sister also is an amazing professor at the university, at the School of Music.
Well,
So,
I love these ideas, and I
so
think
if I say one thing that we could contribute, I think will be to bring in the musical aspect.
I'm excited about that. I have ideas. There's the social support. I think that it's. I would like to also maybe pair something with music with a caregiver support going on at the same time, so that
Yep.
there's caregivers and people living with the dementia, and that we have something for them to do. And so that's one of the great barriers that I've run into. And it's your folks that are going to be able to figure out how to create that content. So that's
You
exciting.
know, one thing I noticed since I came to the Valley, it's like coming from other areas of the US and from Venezuela. We are very, I would say, self-aware. If we don't seem, nice or, here I think that the people are more out there. When we have these activities
In
in the
California,
community.
I don't know. I'll take that challenge.
Oh, when we have these activities out there, it's just unbelievable. Well, I've been in your mini medical school, and I see that also they love to sing quite loud, which is a fantastic cardiorespiratory exercise as well.
Yeah.
And for people with stroke and that kind of I think that's also something that we might tie in the cardiorespiratory impact of certain type of exercise. And I love the idea that you have all the expertise also in acute measurements. And I think that we should begin with the simplest.
Yes.
And we'll ended up hopefully with the implementation that it's accurate enough to help us learn about the implementation, who benefits from whom, from what. But also, I think that just going out there and having the program and inviting the people, I think we are going to make a difference. That's the hope. That's the desire.
It's unfortunate. I have this great clip of one of my health coaches who was with me for the very end, and this does relate to what you just said. And the very first class he had online, he was kind of overwhelmed with the technology. He was really scared about working with older adults because he only worked with like kids and football, and he was an ex semi-pro baseball and football guy, and so he actually got, and I don't know, he might have some mom issues too, but he actually got so nervous that he went outside and puked in the middle of the first session because he was just too nervous. He didn't know what to expect, right? And all of that anxiety about age segregation that happens in our society. Well, now he's absolutely the most favorite of our health coaches, and there's like an army of older adults that he just can't go anywhere in Oakland without somebody sort of giving him the sign. And I think it just comes back to what I told him at that second session when I learned that had happened. If you're not having fun, you're doing it wrong. So this has been the most enjoyable thing of my entire research career because we're all having a great time. Except when I have to worry about money and write grants and stay up all night and stuff like that. Other than that, I'm having a great time, and the health coaches are having a great time.
Good. So thank you so much,
Thanks for having me,
Johnson, and I know this is the beginning of a new thing and a conversation, engagement, and hopefully we're gonna make a difference as much as you've done in California. That's what you're showing, the map that you show. I hope we can show that map of Texas sometime.
immense. We have immense states with immense populations and so unhealthy. The leverage that we have here is immense to make changes. So, well, thank you all for having me. And I'll talk to you all probably in a very near next week kind of thing. Or this